Okay, as we continue with our United Regional preceptor development, this topic is going to be over the medication use evaluation. Now, as we talk about this, you need to appreciate that many times when the resident does an MUE, we will do it for specifically for the institution, and so will the resident. It's something to better what we do, a process, or validate a process or invalidate a process. But many times, MUEs will morph into a resident's research project. And I'm going to give you an example of that. So I'm going to go ahead and go to share my screen, and we're going to start looking at the presentation. And we'll go through it. I'll just do we'll start with just the presentation, then we can go to the sharing. So let's talk about the medication use evaluation. This is something that many of you as pharmacists may have not done before. They're actually, I enjoy doing them. They can be time consuming. It depends how detailed the situation is and how many different departments. They are interdisciplinary, but how many other departments you have to pull into the situation in developing your team, your resources, in order to assure you have come up to a conclusion that is valid, something that is applicable across the system, not just maybe in your little domain. So anyway, I got a drink of Diet Coke. Let's take a look at it. The how and the why of a MUE, or medication use evaluation. So let's start out. You know, I like to write on stuff. So let's start out, but what is an MUE? Let's just define it. An MUE is a systematic and interdisciplinary performance improvement. Remember that, performance improvement method with an overachieving goal of optimizing patient outcomes. Again, I'm emphasizing improvement of patient outcomes by doing ongoing evaluation and improvement of medication utilization. So just by definition of alone, our goal is to do something that overall, the overarching goal is to improve processes as it relates to medications, as it relates to outcomes of patients. Maybe we're going to go back in and review how well prescribers initially ordered enoxaparin prophylactic or therapeutic treatment doses in patients admitted to the hospital. How many times was their initial dosing appropriate? Of those that weren't appropriate, how many times did the pharmacist catch it and make the intervention? Of those interventions, how many times did the pharmacist follow up to make sure the dose adjustment, maybe instead of 1 mg per kg Q24 in 3 days, we can go back to BID? So a patient went from super therapeutic on admission because it was twice daily. We changed it to once daily, but then we failed to, when their acute kidney injury resolved for whatever reason, we didn't readjust the dose. So that right there is an idea of an MUE. Now, do we do something right or wrong at United Regional? We don't know. That's why you do the MUE. But you got to prioritize. So you now, just now, from what I've just said, I promise you probably had 5, 6, 7 ideas just pop into your head. You can't do them all at once, so you have to prioritize. And a lot of times when we do prioritization, it's going to revolve around safety in many regards. Pharmacoeconomics is another one that's important. Are we using an expensive drug? As I always said, if it's something that benefits the patient here and now, we need to use that drug. If everything's equal between 2 drugs, except one cost $100 and one cost a penny, then I'm going to look at cost. A great example would be Dewan had asked me to review hydrochlorothiazide versus metolazone for loop diuretic resistance that we see usually in patients have underlying chronic kidney disease. So they take higher doses, but we're talking about furosemide doses, 200 milligrams or higher in many cases. We've doubled the dose a couple of times, and we're still not getting the urine output. Well, you can add a thiazide diuretic to that, but what we found is hydrochlorothiazide, I guess at the time when we looked at it, was very expensive. It's not that you couldn't get it, but it was not necessarily a cost-effective way of doing it when we could get metolazone oral for pennies, and it showed equal efficacy. So another one would be, from a cost perspective, albumin and plasmapheresis for the volume replacement than maybe using high intensity insulin infusions for that hypertriglyceridemia that has led to pancreatitis. So pancreatitis associated to very high triglycerides. It took longer to lower the number, but the outcomes were the same in the patients. So why not do a cheaper, less invasive modality in certain situations? Consider that. So those are just two quick examples from my world at United Regional. But point one, we talked about if you looked at how to work up a patient, that's when you're looking at the here and now. So that's what a drug use evaluation or a drug use review would be, a DUE or DUR. That is when, as a pharmacist, you are looking at every drug order, and based on what you review, drug interactions, appropriate dose, labs versus drug, indication, that is your systematic criteria-based drug disease specific assessment of individual patients, okay? Now, when you do your DUE or DUR with every order, yeah, many times you're enforcing what we found in an MUE, and that could be changing Protonix to Prilosec or Prilosec to Protonix because we're worried about patients. Back when we didn't have the other P2Y12 inhibitors, we were possibly worried about clopidogrel and the omeprazole drug interaction and lack of efficacy due to cytochrome P450 inhibition. So something to keep in mind when you think about what you're doing day to day. Did this decision to substitute all PPIs to pantoprazole, a lot of times it comes out of an MUE or some type of evaluation of current practices that may be going on. I'm not saying that's the case at United Region. I'm just giving you emphasis and examples. But when we talk about an MUE, we're going to emphasize, again, the improvement of patient outcomes and in some cases, quality of life. And we can only do this if we assess what we're doing. You can't just start a process in a hospital and then go back and not reassess it. All the literature may support what you're doing. You made the right decisions, but did you implement it appropriately in your hospital? Did you do it correctly? Did steps get lost along the way? Are people taking shortcuts, bedside bar scanning? When we first started pushing that, nursing found a lot of ways to find shortcuts. And then we had to make red line rules that if a drug error occurs and it shows that you did not do bedside scanning, that could potentially put a nurse in immediate jeopardy of losing their job because they put the patient in jeopardy by skipping a safety point that had been proven through a process, validated, if you will, to be efficacious and increase medication safety and less medication error. But think global. Don't think on the individual drug level, but think global when you're doing that. And this is a system-wide validation. So, gosh, what's it applicable to? It could be a specific medication. It could be a therapeutic class of medications. One big one that I caught a lot of grief over was going with Anavip over Crofab. I went by the literature and everything I looked at said that use the one that's cheapest, but yet there was a lot of pushback on that for multiple reasons. But again, you have to look, that's an example of a therapeutic class, the disease state you're treating. Are there more efficient ways to treat skin-skin structure infections or a condition, congestive heart failure? What do we need to bring a SGLT2 inhibitor on board inpatient? And literature says we do. Well, which one do we bring on board? And that's where formulary reviews start to play a role, but keep that in mind. Also, when you look at MUEs, don't forget the medication use process. Are we having issues with ordering? Do we need to go back with our IT team and our Epic team, our Willow team, and assure that there's nothing that we can't do for ordering? I want you to think of some of the things just recently that came out. The penicillin desensitization protocol, that isn't, someone recognized the problem with having to put all those dilutions in there. So we work with our IT people to come up with a therapeutic modality and an electronic format to improve the transcribing or the ordering or the carrying out of the process. So something to keep in mind, DKA order sets. Do you use a 2-bag methodology versus a 1-bag, changing the different solutions out based on parameters? Okay, can you go back and look at that and see how many errors that occurred when that happened? How does that affect preparing each of those doses? How does it affect dispensing? A patient going through, or do we need to change the concentrations? I mean, I can go on and on and on of pressors, because it seems like every single patient goes through a bag every hour. Well, if that's consistently the case, then we need to look into either having bigger bags or more concentrated bags. But you can't just make that change. You have to do an evaluation of the current process to make sure what you're about to implement will be better, but at the same time be safe. And a lot of times the safety comes with education. You can't roll it out till all the key players have been educated and made aware of the change. But anyway, the administration of a drug, the monitoring of a drug, we could go on and on and on. Okay, so we differentiated an MUE from a DUE. So, but keep in mind, when you think about MUE, we talked about improvement. It's going to be performance improvement. Some of these will be continuous quality improvement, so you'll always be looking at it. But improvement is the key word, and it revolves around patients. So that's the key thing, and it's going to be an action, and it's an action that we will create, and then we'll recognize, there's your keywords, create and recognize an efficient, safer, cost-effective utilization of medications as part of the overall therapeutic regimen, our goals. So that's what we're doing, but always think, go back up there, think improvement of patient outcomes. We want to optimize the use of medications, and the only way to do that is to evaluate with the critical eye of what we're doing. And don't be afraid to be critical of a process. And it may show to be we're doing everything right, but we could find out we could do this better. So you have to appreciate that. But I gave you the example, and this is a real one. So an MUE is rapid reversal of paralysis utilizing Sigamidex associated with decreased time to extubation in the OR and decreased length of stay. This is an actual DUE I did at a previous hospital. Sigamidex somehow made its way into our OR, and the premise was that when you reversed neuromuscular blockers, this would be a safer alternative because of its mechanism. We won't go into all the details, but this actually morphed into the residents, Julie John, a resident we had, it morphed into her research project, and we published it. But the thought is we would have faster throughput. That's what we were told, anesthesia was saying. We'd have faster throughput through the ER or through the OR. We would have less side effects, such as residual paralysis or a reemergence phenomenon of paralysis when the reversal agent was an acetylcholinesterase inhibitor. And remember, this is going to be, we're going to increase the levels of acetylcholine to specifically with Sigamidex. We're only reversing rocuronium and vecuronium. That was another problem we saw, tried to do reversals with cisatracurium and some of the others. But when you give an anticholinergic agent, you're going to decrease your lower esophageal sphincter tone, which means you can have more reflux and post-operative nausea and vomiting. You can have diarrhea. You can have bradycardia. So we give the glycopyrrolate on top of that, which doesn't cross the CNS, so you don't get those issues. But now we're introducing an anticholinergic to treat the side effects of the drug we're giving for reversal. And so that was the thought, is we could alleviate some of the problems. But yeah, you get lacrimation, you get some issues when you give neostigmine because you're getting more acetylcholine at the nicotinic receptor. But if it was a DUE or a DER and you got an order for Sigamidex, you're reviewing it and verifying an EPIC. Now, this is one that would already been given. This is just for discussion's sake. But let's just say Sigamidex was used for post-op nausea and vomiting. Well, did you know that you need to use an alternative form of birth control if you are given Sigamidex? So, but that wouldn't have anything. But do anesthesiologists talk to their patients about that? So those where education comes into play. And I'll give you, let's just kind of back out of here. We'll come back to the screen. I'm going to stop the share and I'm going to pull up, try to find that. So here's Sigamidex Perry. So let me reshare this and go with this. So let's look. There it is right there. So this would be an example. And I'm just going to go through this real quick. But just to give you an example, what we did when you look at this, the impact of neostigmine and Sigamidex on the time leaving the operating room in a community hospital. you can kind of see what our abstract, you can see what our abstract was. But anyway, we actually did this. And what we told the anesthesiologist, if we don't see a benefit, could we not use the drug? And it's very, very expensive. I'm sure it's not as, it may be less cost prohibitive now, but we were fine using it if it showed a true benefit. And there's a lot more studies coming out saying that it decreases 30-day readmissions if you use Sigamadex over this. The studies I've read, again, I'm not going to get into that, but this just gives you an idea. So, but we did a medication use evaluation and just happened to publish it. But when you look at it, you get your results. And you can see the number of patients or characteristics were same, but the median time from drug administration to OR exit was similar for neostigmine and Sigamadex. We found, and it wasn't statistically significant, but it was a 30-second difference. Now, does that even have clinical relevance? It doesn't. So based on what we found internally, that didn't really support the use of Sigamadex within our institution. Now, we did see a statistically significant reduction in the time from drug administration to OR exit. So, yeah, that's something you got to look at. But again, it was that in case it's 2.7 minutes. So, and then we did linear regressions in terms of side effects, a lower rate of bradycardia. These are the things you can look at, nausea and vomiting. These did not reach statistical significance. They weren't powered for that, but you have to appreciate that this would have been a proof of concept type thing to do more studies. So yeah, when you look at this, this is like, well, we did have less bradycardia. We did have less post-op nausea and vomiting. You got to start thinking, okay, it costs more, but does it give us a safer alternative? So you got to keep looking at it. So I hope that makes sense. That just gives you an idea, though, how these could morph into even a residential research project. And again, this resident, I want to give her credit. She did a really good job with this, Julie John. It wasn't easy. Reason being is because it brought physicians into the fold and asking them to change practice that they don't want to stop doing, even though it was a new drug, because they see it as being more effective. So you just don't say you can't use it, you work with it, but we brought all the players into the table. So I'm going to make reference to that study, that MUE, as we continue to move through our discussion. But I wanted to show you that just to kind of give you an idea where we're coming from or where we're going. So let's jump back into this. So, okay, so we're talking about the MUE. Okay, and I gave you the example. We'll refer back to that Sigamadex. So anyway, the thing was, this was all based on what? It was based on cost. It's an expensive drug, doing 60 to 70 surgeries a day. Not everybody gets VEC or rocuronium, right? So they're not going to be reversed. Not everybody needs a reversal. It just depends. And that's another thing you could look at. Are your anesthesiologists, your CRNAs giving too much? Are they doing their train of 4 twitches? Now, remember, post-operatively, we didn't have access to train of 4 twitching. It wasn't being done. So how efficacious? I will tell you, though, with Sigamadex specifically, since we're talking about that, when you give it, it'll tell you it reverses in about 2 minutes. I watched some of it in the OR, seeing how it worked. It's more like about 30 seconds. You got to be ready because it's going to reverse it quickly. Neostigmine is not as fast. That can actually take several minutes. Okay, so, but I pull that up because it's going to give us a point of reference for our discussions. And I'm going to have a lot of different examples. I've done multiple MUEs, from some of them boondoggles like IV acetaminophen. I'll give you some pointers on that one, which again, forget your data. We're not changing. Sometimes that happens, but we do our work, and that's why you have committees. This isn't something you as a pharmacist, I'm going to enforce this. No, that's why you take this through committee, which we're going to talk about it. But anyway, performance improvement and continuous quality improvements. Anytime these two topics go hand in hand, anytime that I think of an MUE, I'm thinking of performance or quality improvement processes. And this is very important, because when you look at PIs or CQI projects, they certainly tie in to what's expected from regulatory bodies such as CMS, such as the Joint Commission. They typically will ask the pharmacy about, tell me about a PI project that you recently completed, and talk to me about it. And sometimes they just want to hear that you're doing something to continue. One would be the recent introduction of the BD in our IV room. You know, the premise is a safer component, more accuracy. Do you go back in and validate that that actually brought what they advertised to us, because remember, these things usually start with a company or someone approaching us, whether it's the knee we're going to use in knee replacements, or the type of valves we're going to use in a heart valve replacement. Heck, even the type of light bulbs we use in the hospital. Are we getting light bulbs for $1 a piece versus 10 a piece, but yet they burn out in 3 days instead of 30 years? That's a problem. It was cheaper, yeah, on the outset, but over time it cost you a fortune. So it's things you have to appreciate. But keep in mind, when you're doing PI or MUEs or quality improvement projects, these are not research. Now, if you decide to take it to the level of that, that's when you're going to have to get institutional review boards involved for review. But it's not research. MUEs, they're considered operational projects for your organization to have continuous quality assurance assessments and associated improvements. We're not doing this to expand the scientific knowledge for a specific discipline. Now, what you just saw had to get IRB approval because we took it to the masses to say, hey, this is something to consider. In our study there, granted, that was just internal. That's a proof of concept. That's something you'd say, hey, you know what? You got some pretty good signals going on there, especially from the safety perspective. We need to do that not with 100 patients, but with 100,000 patients. But anyway, these do not constitute research. But if you're taking it outside of your institution to share knowledge, to expand the knowledge base that's available, you're going to have to go ahead and just consider it research. So anyway, we're not taking these out. An MUE is not leaving the institution. This is for our own internal improvement. But we want to tie it to an event or a process as it relates to medication utilization within the hospital. That could be the clinical use of medications. That could be the preparation. I used the BD system. Maybe we want to do a medication use evaluation on that. Maybe it's how we're making chemotherapy and the transfer sets we use. Does it create extra steps that could lead to possibly more contamination or spillage? Is there something that might be a one and done process and it makes the process faster, safer, easier, and better for everybody? What about dispensing? Do we want to look at which medications maybe we're not using our automated dispensing cabinet? So you can see an MUE can go multiple directions. The administration of a drug, the waste of a drug, right? What about safety? That's always a very important one. Are we dosing our Lovenox appropriately? And let's look at it. And a lot of times that's what leads to protocol development for a pharmacist to be able to do automatic collaborative practice, policy and procedure approved changes in a medication order without contacting the prescriber within the hospital. But remember, we're trying to validate something a lot of times with an MUE, but when you find a process that you have to make a change on, don't pat yourself on the back. You're not done. You get it done, you make the change, you have to validate your change. You just can't assume what you're doing is better than what they were doing before. You have to validate the change you've made. And the best way to do that, though, is get official committee approvals. If you're just doing a snapshot of something, I get it. But if you're seeing a problem and you want to make an institutional change, you have to have your medical exec committee on board. You have to have your PI committee on board. You have to have your antimicrobial stewardship committee on board. You have to have your, heaven forbid, don't skip pharmacy and therapeutics. That's your first step after you talk to your clinical manager or your ops manager or your director. That's where you go to first and say, hey, I kind of see something that may be, but listen, as a former manager, we get a lot of things put on our plate and you can't look at every single one of them. So you have to prioritize. But anyway, what are our goals? We certainly want to promote the optimal use of medications. That's what we're trying to do. And many times promoting the optimal use is preventing problems or improving patient safety. So very important. Maybe we're going to evaluate the effectiveness of therapy. We know that Sigamidex is going to completely reverse the effects of rocuronium and vecuronium, but not cisatracurium. And when we did our DUE, we found that anesthesiologists were given Sigamidex for cisatracurium and everything else under the sun. So if you have a staph infection and you're giving ACE Trianam, which only causes gram negatives, you're not going to have much effectiveness. So you're evaluating the appropriate use of something. So that's always important. Certainly, this can help us enhance the opportunities in the hospital to do better through standardization. We have heparin infusion protocols. We have diabetes ketoacidosis protocols. We have insulin infusion protocols. We have tissue plasminogen activator protocols. This is standardization, and that's usually to create a situation where the use is appropriate. And number two, the dosing is standardized. It meets what's already been validated to assure we're following what has been established through typically large phase 3 studies. But anyway, something very important. So enhance the opportunities through standardization, and we can assess the value as well when we do that. And those innovative medication use processes or practices, that is very important to look at. And you also want to look at patient outcomes. How long was the patient in the PACU? How many patients who got Sigamidex versus neostigmine glycopyrrolate had bradycardia or post-op nausea and vomiting? What resources did we have to utilize? Did they have to get chased with more glycopyrrolate or atropine? Did they have to be paced? Did they have reemergence phenomenon of paralysis and have to be reintubated in the PACU and supported for 5 minutes, or because it was more than 5 minutes, they just got an admission to the ICU for 24 hours, which changes the entire dynamics of patient safety from an infection perspective, from a medication error perspective, from a cost perspective. So those are the things you have to appreciate and you look at. Now, sometimes the goal is just to minimize the cost of medication therapy. I'm going to use IV acetaminophen. I'm going to show you a little thing. I proved it. I think the concentration to saturate, the serum concentration to have maximum saturation of prostaglandin synthesis in the CNS, I think the magic number was 18. I think it's nanograms per mil, the thing. When you give IV acetaminophen, you get a huge spike. It goes up there and it slowly wears off, just normal. Kinetics are the same. But you get a pretty big spike, and I think that was right around 24. Well, that's 1 gram. When you give, I think 24 nanograms per mil. Don't quote me on the units. But when you give it orally, yeah, you're gonna have slower onset. But the 1,000 milligrams as a tablet barely touches that saturation. Okay, so that's an argument. But one thing we found, if you give the suspension, it kicks in faster, and it actually exceeds that threshold for saturation of prostaglandin activity in the CNS. And so the thought was, well, we'll give you 24 hours post-operative of acetaminophen, but then you need to switch over to suspension. And we were able to prove that from a pharmacokinetic perspective, a correlation between serum concentrations and CNS saturation, we were able to show that and prove it. Now, the next was for an afebrile effect in the hypothalamus, your thermoregulatory centers in your hypothalamus. We know that I think the magic number for this was 8 nanograms of a serum concentration that would correlate the maximum concentration in the hypothalamus, as we talk about thermoregulation. Well, you get it with all these, but, well, they're strict MPO. We have to use IV. So back in the day, this was running. It got pumped up to $30 to $40 a vial. I think it's substantially cheaper now. This is back when it first came out. What did you know? An acetaminophen suppository, let's just draw our line here so we can see it. You would never want to use an acetaminophen suppository for pain. It's not going to even get close, but look what it does. And it cost, what, a penny? When you look at the cost, maybe a penny. So you can see our recommendation was, if you need this post-operatively, okay, you can use it intraoperatively, you can use it preoperatively, but once they're able to take PO, it was an automatic switch, and we just said the suspension. And that was to appease the providers. And there was some pushback, but it went through, and we did see this is why you have to have continuous quality improvement, because we stopped looking at it aggressively and the use skyrocketed again. This is proven in numbers. This was almost $1 million drug in some situations. That's how much was being used. So someone has a fever and they're MPO, and it's not a colorectal type issue. I got to use IV acetaminophen. I remember at the time it was $30 to $40 a vial. I don't know what the cost is now. I'm just using this as an example for minimized cost of therapy. Why not just give a suppository for fever? I just showed you the data that shows that the correlation between serum concentrations and maximum saturation in the hypothalamus, you just have to reach 8 nanogram. I think it's nanograms per mil is the unit. Don't quote me on the units. You see my point though, right? So maybe we're just trying to minimize the cost of medication therapy. Also, you want to meet or exceed your internal or external quality standards. Now, this is where external CMS comes into play. Our SCIP measures, our CHF measures, our stroke. We're a certified Joint Commission certified stroke center. Are you sending your patients home on intensive statin therapy? If not, why? Is there a holdup for it? Try to find why we're not staying in tune with those professional practice standards, those accreditation standards, those government laws and regulations. You got to ask yourself why. And then when you ask yourself why, then you get to define the what. What are you going to do about it? Okay, so MUE processes, and I have all kinds of forms to help. You all know how to get in touch with me to find these. But again, and I do hope that I'm sharing the right screen again, because it just went right back to this. Let me see. I hope I am. I just stopped my share again. I can't find it. I guess it doesn't matter. I just hope I'm sharing the right screen again. Anyway, back to this, the share. Okay, so the focus PDCA, some will do a PICO, but you want to find the process to be targeted for improvement. This is the what you're going to improve. You got to organize the team that knows the process. This is going to be maybe your information technology team. This is going to be nursing. This may be physical therapy. This may be the microbiology lab. This may be the emergency department. The list goes on and on. Certainly the medical staff. So, but you have to have a team of movers and shakers and thinkers, and those who are respected and can push and implement change. So you want to clarify the current knowledge of the process. So what is the process we're doing now? You want to clarify that. You want to make sure everybody understands the process, and then why maybe that was adopted at a certain point in time that could maybe not. For example, gram-negative bacteremia with E. coli. 10 years ago, I'd have told you to treat it for 10 to 14 days. Now I'm going to tell you to treat it for 7. Does that make the current process wrong if it's 14? It does not. It just means that there has been new data to support 7 versus 14 days. And so you have to clarify your process. When the decision was made, it was in good faith, and that was an accepted practice. But now we have data that supports a 7-day course of therapy versus a 10 to 14-day course of therapy. So you got to clarify the current knowledge and just think, okay, was this just something people did willy-nilly, or was there a basis for it? And you got to appreciate that, and you got to make sure the basis for it is not still acceptable. But understand the root cause of process variations. This may be what you are trying to answer. Why on maybe the 5 West bedside bar scanning is only at a measly, let's just say 90%. And then you go to 9 West, I'm just making these numbers up, and maybe they do it at a rate of 95%. And then you go down to 3 West in the ICU and they have 100%. Okay, what's going on between the floors? Is it just because it's not being done, or is there a root cause for the reason? Well, we don't have scanners. Our scanners don't work. The drugs we get aren't barcoded. I'm just making stuff up. But you got to ask yourself, what's the root cause of the variation in a process? Select the and sometimes it could just be, well, that's just how we've always done it. Well, you got to follow the processes. But then you got to select your process for improvement. Then you got to develop a plan or a solution, right? Then you got to do it. You got to implement those improvements, but once you implement them, you're not done. You need to evaluate your results. Did you put something in place that what you were doing was better? And it's okay to admit, you know what, we were wrong. And it's not you, it's we. This is a process improvement, a team improvement. You have to keep stakeholders, and you were looking to do what you thought was best for the situation that was presented to you. And then when you do evaluate your results, you need to act. You got to determine what changes are needed moving forward. And how are you going to implement those changes? And this can take time. This isn't a process that happens overnight. You're looking at sometimes months to even years. So this is straight from ASHP, but this is some an MUE objectives and examples of what you can do. Well, we're not going to go through these. You can read them. You can pause me. But promoting optimal medication therapy, maybe you're going to compare the efficacy before and after the introduction of a biosimilar therapeutic substitution policy. Or maybe you're going to compare the efficacy of Sagamedex versus neostigmine glycopyrrolate. It could be anything. But you can go through these, but you can see that there's multiple types of topics when we talk about medication use evaluations that we can go from, and this can kind of give you an idea. But you can see the big emphasis is we can't do them all. We have to prioritize. You may have 100 different things you need to get done, but maybe we can only focus on one or two major projects within a year, and that's what our residents are going to be doing. We'll have 2 residents, and they're going to each have a major project they're going to do, and it's probably going to be tied in some form or fashion to a medication use evaluation. And you don't want them to do it just to get the experience, because that's wasting everybody's time. You want them to do something that can maybe be applicable and have an appropriate potential outcome for our institution, but better yet, the drug utilization for our patients. So medication use began prescribing, dispensing, the administration of drugs, the monitoring of drugs. Are we monitoring for QT prolongation for certain medications, droperidol? I don't know. You don't really have to monitor for that with droperidol. I know what you're thinking. No, yeah, you do. No, you don't. But that's a different story. That would have been a DUE. There you go. That's one right there. If the hospital was using previous discussion. But there's a lot of stuff that goes into it. So prioritize the opportunities. So the amount of time to do it. This is where residents can help, and this is where our residents are going to play a big factor. And we need to make sure, though, we prioritize. We give them a medication use evaluation project that is worthy of consideration of making a change within our institution. So it could be, we talked about the various ones. You want to talk about high-risk medications for adverse effects, toxicity, especially those when the word has the D word, death, into it. But for example, reintroducing droperidol use in the ED, that brought a lot of angst among people for sure. Thalidomide use in leukemia, when that came back into play, we had to put safety nets into play because, for pregnant women, that can lead to phocomelia and not good. High risk of drug food interactions. If you're working in a transplant institution and the risk of graft rejection, for example, that's going to be something you got to make sure that medication's being used, right patient, right time, right dose, etc. What about those high-risk medications or those medications that are used quite often by many patients? PPI started in the ICU, but they continue through the transition of care to a step-down unit to discharge and beyond. They go home on it. They don't even have an indication for it. Disease-specific practices, antiplatelets utilized in the cath lab. When we had clopidogrel, we were using that, but didn't realize that you didn't really get an effect from clopidogrel for about 8-9 hours after the fact. We also found out from a pharmacogenomic perspective, those who were slow metabolizers never metabolized the prodrug into the active drug, and they would go home the next day with their new stent and show up 48 hours later with an in-stent thrombosis because they weren't getting appropriate antiplatelet activity. High use of vancomycin for CAP doesn't make sense. MRSA pneumonia, MSSA pneumonia is very rare. When I think it's appropriate in the hospital, if you're coming in with the post-viral syndrome, because we do know that you can have a lot of issues with post-viral pneumonia, bacterial pneumonia, after you've had the flu. And for whatever reasons, a lot of times it is staphylococcal in nature. Medication utilization, the oral metolazone versus IV chlorothiazide and loop resistance. We talked about that. Formulary medication is added with restrictions. Do we need to follow up to make sure the restrictions are followed? And number two, that it's the anticipated benefit based on review and literature is what we're seeing in our patients. And that would be, I use the Anavit versus Crofab, maybe ticagrelor versus prasugrel. There's a reason why your cath patients are all getting loaded with ticagrelor, but then they'll go home on clopidogrel, depending on the situation. FDA alerts, sometimes that will excite an MUE. EUAs, that's a big one. We use these drugs, well, there's an emergency authorization, and we willy-nilly allow them in our institutions, but these are not FDA approved. But we're going to allow it. Does it increase safety issues? And the one I like to bring to attention is remdesivir. Pharmacoeconomics, I talked about IV acetaminophen. That was a nice example. Already defined medication use guidelines. So the guidelines are in place. Is there medical staff compliance to the approved restrictions? Now, we may do the digging, but again, that would go to a higher level of authority for enforcement. And then, of course, those pharmacist-driven collaborative practice, that's very important. Pharmacy to dose Fanco, IV to PO, renal dose adjustments. Are the pharmacists, we have to critique ourselves. Are we doing what we're supposed to do appropriately and making the right decisions? Are there pharmacists who are deficient in a process and they need more training? As a group, is there something we're doing wrong that we could make a change to be in line with best practice? So you always got to look yourself in the mirror as well. So anyway, you've completed that focus. Everybody agrees. What's next? And that's where I like to use FACES. Answer these questions as applicable. Feasibility, how easily and quickly can the change be made? Sometimes changes happen over more than a year. Acceptability, how willing are those impacted to make the change? Are they willing to do it? And if you have an entire medical staff raise up against you, that may be hard to deal with. If you have one or two outliers, that may be easier to deal with, or would be. The cost benefit. Do the cost outweigh the benefit of the medication? Sigamidex versus neostigmine. I guess if we can decrease 30-day readmissions, decrease post-op nausea and vomiting, decrease the need for re-intubation, you got to prove it. But if you can do that, I don't think cost matters anymore because there's a real benefit. So it's not about cost. Then effectiveness, not does the drug work or not, but how effectively will this change solve the problem? In other words, what you implemented based on your MUE, did it solve the issue that you had to find? And if not, did it make it worse? And then sustainability, this is the big one. This is why you can't have too many things going on, because you have to be able to sustain it. And the only way you can sustain it is doing continuous quality improvements. And will it last over time? This is probably one of the biggest things. Once you put something in place, can you sustain the process? And my experience in pharmacy processes is you'll put an IV to PO program in place and everybody's on board, then people stop doing it. And then as my days as a clinical manager, I would run these reports and see who did what. And a lot of times it can lead to conflict and controversy because there's always excuses, and I'll just leave it at that. But is it sustainable? So you want to avoid failure, and these are very good. This again is straight from the American Society of Healthcare Pharmacy. But lack of authority, you have to make sure you're going through the appropriate committees with the appropriate people. You have to have organization, you have to have structure, and you have leadership. If you don't have that, don't try it. Poor communication, you have to make sure that everybody understands what the goal is. You have to make sure that everybody understands what their job is. You have to make sure that IT knows exactly what's expected of them. You have to know what maybe nursing, what's exactly expected of them in the process or the review. Poor documentation, always you have to document what's going on, summaries of the action, the findings, the conclusions. You have to do that. Lack of involvement. Remember, I'm just going to read this straight. The MUE process is not a one-person task, nor is it the responsibility of a single department or professional group. We're all in this together. And those medication use criteria or what we come up with is going to get sent to the appropriate committees for approval or disapproval. And if they say no, you can't go rogue and, well, I'm going to do it anyway. Okay, so you have to have involvement. You want to make sure your data integrity, when you collect data and you have multiple people pulling data, you got to make sure it's consistent and everybody's getting it from the same place. This was very difficult when we were doing our Sagamadex review because different documentation occurred in different places or a lack thereof. There wasn't one systematic way that anesthesia was documenting which drugs they were giving and which ones they weren't. You'd find it written in a note, but you wouldn't see it on the administration record. And this was all before the electronic health record had been deployed specifically to the operating room. Lack of follow through. You can't do a one-time study or evaluation and then just let it go. You have to do continuous quality improvement. So always keep that up. It's always important to do that. But anyway, you can go through the rest of these and read them, but these are just failure modes. And it's good for the residents that are watching this or the pharmacists that are going to be over the residents for an MUE to appreciate the potential pitfalls and potential barriers of successfully completing your medication use evaluation. So again, as we get to the end of this, you have the what, the systemic analysis of the defined problem with the goal of evaluating and improving that problem or that process. You got to have a rationale, the why. And has anything been done in the past that didn't work? Don't repeat what hasn't been effective. The expected benefits, are you hoping to get a guideline or a protocol change? Are we trying to find a way to mitigate adverse events or problems? It could be a multiple things. Is it pharmacoeconomic? Is it direct or indirect cost? An example, fidaxomicin, that's a good one because there's some studies that show using fidaxomicin in the hospital, even though it's more expensive, may be more cost effective than using vancomycin in the hospital. That's just, I'm not saying I support that statement, but I'm just using it as an example because the study's out there. Well, do you make the change? If you do make the change, you need to come back in and make sure, okay, the numbers needed to treat to prevent one reoccurrence is 15 million. I don't think that's going to be cost effective, but you get my point. You have to, once you put something like that in place that's going to cost more, is it saving you on the back end with readmissions? You have to look at that. Anticipate the challenges, right? Time. It's not an issue as the resident will be doing this. Wait, it is going to be time. The residents don't have 24 hours a day, 7 days a week to work this. But again, this is one of the benefits of the resident is they can do these for us as part of their projects when we might not have the time to do it. But that's why we usually only have one major project. There can be several MUEs throughout the year and working in collaboration, but usually these morph into a project. So pre-MUE, the step-by-step, again, establish the problem and get the organizational authority. You got to get your primary person who's going to be in charge of designing, conducting, and reporting the results. Got to define those processes and outcome measures, whether it's already established guidelines. And it can't be something you make up because then it's not validated. I've seen that before. People define, well, I'm going to define acute kidney injury as instead of a 50% change or a 0.5 milligram per deciliter change in serum creatinine, I'm going to make those numbers a little bit more conservative and do this. So that makes my result. You can't do that. You have to define your outcome measures based on accepted measures. Otherwise, you're validating the validator. Define the time period and define your sample size, which will vary in what you're trying to do. The data collection, you're going to identify the person for whom an agent or drug class has been prescribed during a specific time frame, and you're going to get your reports. Now, if you're doing it as a quality assurance program, you'll need at least 30 patients to get a snapshot. Proof of concept, right? But usually 30 to 50 is sufficient. If you're going to do it for your major project, you're going to have to be more. But to have a cadre or a cohort, you're going to have at least more than 50 patients to consider point of prevalence study or a systematic random sample. Now, I'm not going to get into discussions about what do you have to assure that you have 80% power. That's a whole nother story. We're talking about MUEs. When you get to that, we're talking about research. This is medication use evaluation discussion. So there you go. Design your data collection tool. Find your spreadsheet expert and use them where you can plug data into your data points and it's doing auto calculations for you. And this ties in directly to make sure that when you collect data, it is standardized. Make sure you're all going to the same part of the chart for the same information. And then you're going to compose that MUE report, which is just a report on the data you collection. That's when the data becomes information. Now, when you compose your report, you're putting this data into a format to start crunching numbers. I have a nice abstract writing cheat sheet that you can use, fill and ask for it. But objectives, you want to characterize or explain the intent of the MUE. Then you're going to do your background and your rationale. You're going to state the reason of the rationale for the MUE. You're going to define your criteria for evaluation. What was your performance indicator? What makes it a yay? What makes it an A? You got to include those thresholds and proof of criteria. Remember, don't create your own scale because you're looking for validation. So you have to make sure that you're using a validated scale, if you will. So as I put in there, if you make up your criteria, if it's not validated in such a case, your objective is to validate the criteria. And that may be validate the criteria for appropriate use of zinc for COVID. You're not asking if zinc for COVID works. You're just asking, can we validate the criteria used to decide who gets zinc for COVID? I'm just making this up. This is just stuff I pulled off the top of my head, for example. So anyway, make sure you have criteria that's validated. For example, if it's renal dose, if the studies say that your renal dose enoxaparin when your estimated creatinine clearance is less than 30 mils per minute, that's your definition, not 31, not 29. It's less than 30 or 30 or less. That's what you got to go by. You can't say, it's 31. I'm going to call it 29. You could be. You could say there's no way their creatinine clearance is 30. So you got to go by your numbers. Methods, this is the details on how on your design, what you did to get your data. And it could be PubMed, it could be stuff you pulled out. If it's something more of a meta-analysis, it could be that. Then your results, this is what your data told you. This is what it told you. Then a conclusion, what you think of everything you just did. Make sure you're answering the question that prompted the MUE and then the limitations. Don't make this difficult, okay? Just simply outline unexpected hindrances to data collection that possibly or may have created some bias to your results. There's no reason to not do that. It's not a knock on yourself, but reason for potential invalidation. And then the recommendations, that's self-explanatory. This is what you're going to suggest, which could be no change at all as a result of the good work you've just done. So in the end, you want to report your findings to the proper committee that gave you the initial approval for the MUE. You want to follow directions from the committee. This could be multiple walking orders, develop and implement the plans, right? Based on your findings. It could be change mediation. That should be medication related processes or guidelines, protocols. A plan to validate. They may say, okay, we're going to make this change, but we want you to come back in 6 months and give us a snapshot on how it's working. So repeat your MUE, but maybe with abbreviations to it, just to make sure the change that you're doing, well, continuous quality improvement. That's what we're talking about. So you got to schedule those regular assessments as needed. And it may be you go back to P&T once a year and say the use of acetaminophen IV is remaining at the appropriate level, or the use of antibiotics, the list could go on. But then your timeline, design development, and I have templates, but 2 to 4 weeks. This is just me. IRB approval, if applicable, can be 1 to 2 weeks if utilizing external IRBs, longer if it's internal. Some meet every week, some meet every month, some meet every 3 months. It just depends on the situation. This is something we're going to have to work through at United Regional, is the IRB process, if it's something that is being taken to the level of a research project. But the MUE, you don't need that. The data collection, this is what's going to take most of your time, and it can take anywhere from 4 to 6 weeks. I think anytime you have free time, you collect data. If you find yourself twiddling your thumbs for 30 minutes, use that 30 minutes maybe to review 2 patient charts. And that's 2 less you have to do. So I always appreciate that. The analysis of the data, you're going to massage it out, how you look at it. That can be anywhere for 2 to 4 weeks. And then, of course, the presentation, I have templates for that as well. But again, it's going to be your conclusion. So if you have any questions for this recording, you know where to find me. So I'll stop the share, but that is the how to do a medication use evaluation. I hope you found it helpful. I apologize for the glare behind my head, but I'm doing this in my office at home. So anyway, please enjoy this. Again, these are just preceptor developments, and it's also for our residents that'll come in to get an idea of what we're looking for when we talk about a medication use evaluation.